This module will be about the discussion of cyanotic congenital heart defects. As I have said before, cyanotic heart defects are less common compared to acyanotic heart defects. First, let us look at the types of cyanotic congenital heart defects. There are two types. One is obstructive lesion. Here, I mean obstruction to the pulmonary blood flow resulting in decreased pulmonary blood flow. When the pulmonary blood flow is decreased, the lung is getting less blood than usual. This results in decreased oxygenation by the lung, predisposing to cyanosis. The next category is mixing lesion, where there is a mixing of deoxygenated blood with the oxygenated blood, thereby decreasing the oxygen saturation in the blood and predisposing to cyanosis. In mixing lesion, usually there is increased pulmonary blood flow. So these are the two categories of lesion, and generally remember obstructive lesions are more common variety compared to mixing lesion. So first we will discuss about obstructive lesion. There are three obstructive lesions that you should be knowing about. One is tetralogy of Fallot. Number two is tricuspid atresia. And number three is Epstein's anomaly. And as I have said before, the tetralogy of Fallot, or what is remembered in short form as TOF, is the overall most common cyanotic congenital heart disease. So let us discuss this category in detail first. As the name suggests, tetralogy refers to tetra, which is 4 components. So definitely there would be 4 components in tetralogy of Fallot, which includes number 1 is overriding of aorta, wherein the aorta, after arising from the left ventricle, slightly shifts to the right side, or it overrides to the right side of the heart. That is what is meaning of overriding of aorta. The second important problem is RVH, which is right ventricular hypertrophy. That is the second important problem. Third important, you can see that marked as enlarged right ventricle here. Third important problem is the presence of ventricular septal defect, VSD, ventricular septal defect. But please remember here, because of right ventricular hypertrophy, there is increased pressure on the right side of the heart, okay, when compared to the left side. So what do you think will be the shunt in this VSD? It is from right side to left side, right? Right side to left side. Always remember, through a shunt or through an opening, blood always flows from high pressure to low pressure. Here, right ventricle is high pressure, so it flows from right side to left side across the VSD. That's the point. Now, fourth is the very, very important point. Okay. It is called as pulmonary stenosis, but that is not a correct word to be remembered. The actual type of stenosis encountered in tetralogy of Fallot is subpulmonary stenosis. Okay, you do get pulmonary stenosis in some cases, but subpulmonary stenosis is far more common compared to pulmonary stenosis. This is the point I would want you to remember first. Next, I am going to explain what is this subpulmonary stenosis. Subpulmonary means below the pulmonary. It is below the pulmonary artery and below the pulmonary valve also. You can see in this picture, this is the pulmonary artery. Let's imagine that this is the pulmonary valve region. Okay. The stenosis is something below these two areas. That is what I mean by subpulmonary stenosis. What is below the pulmonary valve? It is a right ventricle. And the part of right ventricle which is below the pulmonary valve is called as the infundibulum. Infundibulum, which actually forms like this beautiful tract, like this tract for the blood to flow from the right ventricle into the pulmonary artery. Are you able to follow this? This area is called as a infundibular area, which is actually a part of right ventricle only. And because it is forming a nice tract like this, it is also called as RVOT. What is RVOT? It is right ventricle outflow tract. OT refers to the outflow tract. Now, what is happening in tetralogy of Fallot is the infundibular area becomes hypertrophied. There is hypertrophy. So what is happening? That area is becoming thick like this. It is becoming thick like this. Are you able to follow this? Now, very important, when it becomes thick like that, what is going to happen to that area? It has become narrow. Are you able to follow this? Or in other words, the outflow tract in that area has become narrow. Okay. So this results in narrow RVOT, or I can also call it as RVOT obstruction. Okay. So putting it all together, what I meant by subpulmonary stenosis is actually the infundibular hypertrophy or RVOT obstruction. That is the main point which I want you to remember out of all these 4 features. Why it is considered as a main feature? Because this feature determines the development of cyanosis. Or in other words, a famous MCQ question is here. The main determinant of cyanosis in tetralogy of Fallot is RVOT obstruction. Very simple. In RVOT obstruction, what happened? There is a decreased pulmonary blood flow. Obviously, when the pulmonary blood flow decreases, I have already explained that the child will develop cyanosis. So that is the meaning of main determinant of cyanosis in case of tetralogy of Fallot. You can also understand that there is one more cause of cyanosis, which is the right to left shunt, which is occurring through VSD. Whenever there is right to left shunt, what is happening? There is mixing of deoxygenated blood with the oxygenated blood. That is going to go to the aorta further, and that will go into the system. That can also contribute to cyanosis, but the main determinant is always RVOT obstruction. That should be remembered. So many MCQs I've just tried to cover from this slide itself. Okay. Now, just for your MCQ purposes, you should know other terms also called as pentalogy of palate. What is the meaning of penta? Penta means 5. So 5 features are noted, wherein you have tetralogy of Fallot, which by itself will be 4 features. Along with that, you have the 5th feature in the form of ASD. That is what is pentalogy of Fallot. Then the next one, that is triology of Fallot. Here, there is ASD, atrial septal defect. Next is pulmonary stenosis. With intact ventricular septum. What is the meaning? There is no ventricular septal defect here. That is what I am trying to tell you. Third is RVH or right ventricular hypertrophy. These 3 features are what we call it as the triology of Fallot. Okay. This is purely for exam purposes. That's all. We don't see much cases like this pentology and triology. Just for exam purpose, you need to know. Now let us focus back our discussion on tetralogy of Fallot. Let us see what are the consequences of tetralogy of Fallot. First feature is obviously cyanosis, and I have told you the reason for cyanosis as well. Okay. Now the main question is, when do these children develop cyanosis? Remember, it is very, very variable. Why? Because it depends on the degree of, or it depends on the severity of RVOT obstruction. What is the meaning? If the RVOT obstruction is very severe, it can present even in the neonatal period itself. If it is of less degree, it can present at a later age. Okay, that is what I meant by depending on severity. But as a common point, you can remember, most of these children, they develop cyanosis within 4 months after birth. Within 4 months after birth. And another important point to be noted is, once the cyanosis develops, it is going to be progressive cyanosis. Okay, right. Why? Because as the child grows older, the narrowing of the right ventricular outflow tract also becomes increased. That is why it is a progressive cyanosis. So these are the salient points for cyanosis in tetralogy of Fallot. The other features include, because this being a progressive condition and a chronic condition, the child will have inability to gain adequate weight or height, resulting in failure to thrive. That is the second feature. Failure to thrive. The child will have less weight than expected. The child will also appear short and things like that, which is what is called as failure to thrive. The third important feature is some findings which you get on examination of this child. When you auscultate these children, you will hear a single second heart sound. The reason being, only the aortic component or A2 is heard. The pulmonary component is usually not heard because of narrowing in the pulmonary region. And can you get any murmur in case of tetralogy of Fallot? Yes, of course, there is a murmur at the pulmonary area. Again, due to blood flowing through that narrow pulmonary region, you get a ejection systolic murmur at the pulmonary area. Very, very important. Ejection systolic murmur. That is a classical murmur because of blood flowing through that narrow pulmonary region. Simple. Now, there may be one question in your mind. What about the VSD murmur, which is pansystolic murmur? VSD is also present in case of tetralogy of Fallot, and through the VSD, blood is also flowing from right side to left side. But that murmur is usually not heard. What is the reason? Reason is because the ventricular septal defect which occurs in this tetralogy of Fallot is a large VSD, number one, and number two, it is a non-restrictive VSD. What is the meaning? It will not create any turbulence when the blood is flowing through the defect. That is the important point. There is no turbulence. That is the reason why there is no murmur heard, because of blood flowing through the VSD. I hope you are able to get the point. So the only murmur noted in tetralogy of Fallot is at the pulmonary area, and that is ejection systolic murmur. This should be very, very clear and asked as exam questions previously. Right. Now let us look at what are the complications of tetralogy of Fallot. As I have told you, this is a chronic condition and a progressive condition. So definitely complication will develop over a period of time. Some of the important complications include infective endocarditis, the reason being there is a turbulence of blood when it is flowing across that narrow pulmonary region, and because of that turbulence there can be damage to the part of right ventricle which can predispose to the development of infection. So one is infective endocarditis. Number two, long-standing cyanosis. Results in chronic hypoxia. Whenever there is chronic hypoxia, please remember that from the kidneys there would be a release of erythropoietin, EPO. This erythropoietin will stimulate or increase the levels of erythropoiesis occurring in the bone marrow, and that results in increased levels of RBCs in the blood. What do you call this increased RBC in the blood? It is polycythemia. So the next complication is polycythemia. Okay. Now, polycythemia is a condition of more RBCs in the circulation. So what would happen? It would increase the viscosity of the blood, and that can result in increased risk of thrombosis. Okay. Thrombosis in the circulation. And some of this thrombi can become detached and enter into the circulation, causing thromboembolism. Okay, right. Generally remember, most of the thrombi are getting generated in the venous circulation. So think like this, a thrombi is generated in the venous circulation, gets detached as thromboemboli, comes through the venous circulation into the right side of the heart. Imagine. Okay. Now from the right side, that is right atrium initially, it enters into right ventricle. And from the right ventricle, what is happening? Through the VSD, it is entering into the left ventricle, and from the left ventricle, it is going to enter into the aorta and the systems. So what is happening? An emboli, which is originating in the venous side of the circulation, now entering finally into the arterial side of the circulation. This is what we call it as paradoxical emboli. Paradoxical emboli. Very important. Okay. Okay, so that is the next complication. Suppose there is a paradoxical emboli which is originating, and unfortunately, if it is a septic emboli that is associated with an infection, what can happen is that it can enter into the different systems, especially it can enter into the central nervous system, predisposing the patient to develop infection inside the brain. And what is that infection? It is brain abscess. So the fourth important complication is brain abscess. Here is an MCQ question related to this. What is the location of brain abscess related to tetralogy of Fallot? It is in the parietal lobe. It's an important exam question. Okay, that is important. Okay, so that is a fourth complication. The fifth important complication is a common exam question, whether it's an institute exam or a screening exam or your university exam. Definitely questions are expected from this. What is that? It is something called as the TET spells, or also called as the hypercyanotic spells, or also called as the hypoxemic spells. It is a very important complication occurring in a child with tetralogy of Fallot. Let us discuss that in detail. Okay. So, how does this spells start? It is due to a condition called spasm of infundibulum. Spasm of infundibulum. Now, the spasm of infundibulum is precipitated due to some factors. Like for example, the child is having excessive cry or vigorous feeding or an exertion. Imagine like this. Okay. This results in the spasm of the infundibulum. Now what is the problem here? Already I told you in tetralogy of Fallot, the infundibulum is hypertrophied, causing narrowing of the right ventricular outflow tract, right? When spasm happens, it will become even more narrow like this. Are you able to follow? When it is even more narrow, there is even more severe degree of obstruction. Very simple. So spasm of infundibulum results in increased narrowing. So tell me what will happen to the degree of cyanosis if there is increased narrowing? Yes, it will become worsened. It is worsening of cyanosis. Worsening of cyanosis. So that is why you can understand the meaning. Hypercyanotic. What is the meaning? The child who is already cyanosed now becomes more cyanosed. That is why it's called as a hypercyanotic spell. So worsening of cyanosis will get reflected as worsening of hypoxia in the blood. Worsening of hypoxia. Whenever there is worsening of hypoxia, there is more and more of anaerobic metabolism happening, right? Because of hypoxia. So this results in worsening or increase in lactic acidosis, because we all know that when anaerobic metabolism is occurring, it is a lactic acid which is produced more. So there is worsening of lactic acidosis. This combination of acute worsening of hypoxia and lactic acidosis will stimulate the respiratory center of the brain, resulting in hyperventilation. Hyperventilation. Now this hyperventilation results in increased chest expansion, thereby predisposing to increased venous return also to the heart. Now venous return, where it is going to come to? It is going to come to the right atrium and then goes to the right ventricle. Now at the end of right ventricle, you are having the infundibulum, right? What happened? When more blood enters into the infundibulum, it will again precipitate more spasm. So it goes on like a cycle like this. This is what we call it as a vicious cycle of the hypercyanotic spell. Very, very important to know this, because only if you know this cycle properly, you will be able to manage these children also. The management can be easily remembered by tackling all the components of this cycle. For example, there is worsening of hypoxia. So in the management, you can give oxygen as a treatment. So oxygen supplementation can be given for these children. Lactic acidosis is there. So to counteract the lactic acidosis, you will give what? Sodium bicarbonate. Okay, that can be used in the treatment. Third is there is hyperventilation, right? So you can give a drug which will decrease the activity of the respiratory center of the brain, thereby decreasing hyperventilation. What is the drug? Yes, it is morphine that can be given. I told you that there is spasm of the infundibulum, right? So to decrease the spasm of the infundibulum, you can give a beta blockers. Drugs like esmolol, propranolol can be given in this situation. Now, if you look at children during the time of cyanotic spell, they adopt a posture called as squatting. Okay. What is the advantage of the squatting? When the child is squatting, you can imagine that the thigh region is getting compressed. Because of the thigh getting compressed, the blood vessels in the thigh, namely the femoral vessels, are also getting compressed. For example, if the femoral vein is undergoing compression, what would happen? The venous return through that femoral vein will be decreased. This will result in decreased venous return. That is advantageous, right? Because I said that increased venous return will precipitate further spasm of the infundibulum. So when you decrease the venous return, that would decrease further spasm of the infundibulum. Very simple. The next mechanism is during squatting, there is also compression of the femoral artery as well. Femoral artery is a part of systemic artery. So when the femoral artery is undergoing compression, what will happen to the pressure in the femoral artery? It will increase, or in other words, there is increase in the resistance of the femoral artery. The increased resistance in the femoral artery will be reflected as increased resistance in the systemic arteries as well. Or in other words, I am going to write there is increase in systemic arterial resistance. Okay, systemic arterial resistance is increased. So what is the advantage? Let us look at it like this. Systemic arterial resistance increase means there is an increase in afterload of the heart. What is the meaning of afterload? It is something related to the aorta, where the pressure in the aorta is getting increased. What is the advantage here? When the pressure in the aorta, I am writing like this, increased pressure in the aorta, what will happen is, think like this. This is a schematic description of what is happening in tetralogy of Fallot. There is a VSD here, through which the blood is coming from RV into LV, right? That is what I was telling you before also, right? Now what happened? This is a deoxygenated blood from the RV entering into the LV, which is contributing to cyanosis. That's what I told you previously. Now, when you increase the pressure in the aorta, what is going to happen? This blood coming from RV into LV is also decreased. Why? Because of so much of pressure on the other side. Are you able to follow this? Or in other words, increased aortic pressure effectively decreases the amount of deoxygenated blood entering into the left ventricle and subsequently into the aorta. I hope you are able to understand this. And because of this, what happens? There is decrease in the amount of cyanosis. That is the another advantage of squatting, wherein the pressure in the systemic blood vessels like aorta is increased, thereby decreasing cyanosis. I hope you are able to follow this. So squatting helps by two ways. One is femoral vein compression, second is femoral artery compression. For your exams, remember the role of femoral vein compression is more described when compared to femoral artery compression. Okay, right. Now, an older child can do squatting. That is possible. But for a small child, squatting is not possible. Like for infants, squatting is not possible. So as a squatting equivalent, what we will tell the mother is to bend the knee of the child and keep it over the chest. This is what we call it as a knee chest position. You can easily imagine that in the knee chest position also, what will be getting compressed? It is the thigh which will be getting compressed. When the thigh is getting compressed, automatically the femoral vessels also will get compressed. That is why I am saying knee chest position is the equivalent of squatting in young children. Okay, right. So this is the next way of managing the cyanotic spell. I told you increased systemic arterial resistance will help in decreasing the cyanosis, right? You can also give some drugs to increase the systemic arterial resistance. What could be the drug? Yes, it is a alpha agonistic drugs. A typical example of this is phenylephrine. This is also useful in the management of cyanotic spells. Okay, so quickly revise what are all the management aspects of cyanotic spell. One is oxygen, second is sodium bicarbonate, third is morphine, fourth is beta blockers, fifth is squatting or the equivalent is knee chest position, and sixth is alpha agonistic drugs like phenylephrine. So I hope you are able to get an idea of what is the problem in cyanotic spell as well as management of cyanotic spell. So that completes the important complication occurring in case of tetralogy of Fallot. The next one to be remembered here is what is the X-ray finding in case of tetralogy of Fallot. I know that most of you will be knowing the answers. What is it? It is a classical boot-shaped heart. Can you see that? This is a typical description of the boot-shaped heart. So it's called as a boot-shaped heart, or also called as a coherent sabot. Okay, what is the reason for this boot-shaped heart? That's an MCQ question. We all know that there is right ventricular hypertrophy in tetralogy of Fallot, right? Right ventricle actually occupies this area. So this area becomes very, very huge due to right ventricular hypertrophy. So what is the problem? It is going to push the left ventricle slightly upwards. Where is the left ventricle? It is usually on this side. So what happens? There is a pushing of the left ventricle slightly up like this. So the left ventricle border gets shifted in this position. And this pushing up of the left ventricle, or this area is what we call it as the apex. So pushing up of the apex is the reason for this boot-shaped heart. And what is the main reason for pushing of the apex? It is right ventricular hypertrophy. So as a single reason, you can remember right ventricular hypertrophy. And as an expanded reason, you can remember right ventricular hypertrophy leads to upturned or pushing up or pushed up apex. That is the reason for tetralogy of Fallot having a boot-shaped heart. Finally, we come to the treatment of tetralogy of Fallot. We can divide the treatment into two categories. One is a definitive treatment. Another one is a palliative treatment. See, according to the present guidelines, it is advisable that tetralogy of Fallot should be operated by definitive treatment as early as possible. So early diagnosis is the key in tetralogy of Fallot. Okay, and what is the timing of definitive surgery? It should be done within 3 months after birth. That is what is the present guidelines telling you, because this time period is crucial. Why? Because if you delay the surgery, there will be invariably lot of complication, including recurrent cyanotic spell, which is not desirable in a child. That is why early definitive surgery is advisable within 3 months after birth. This is the current consensus regarding treatment of tetralogy of Fallot. Okay, of course, it depends on many factors. Suppose the child's anatomy of the heart is very, very complex in such a way that you are not able to do the definitive surgery, then the only option for that child would be palliative surgery. Now, palliative surgery is usually in the form of shunt surgeries, and the aim of this shunt surgery is to improve the pulmonary circulation. Or in other words, you can remember improving the blood flowing into the pulmonary artery. If you remember, the basic reason for cyanosis in tetralogy of Fallot is nothing but decreased pulmonary blood flow. So palliative surgery or the shunt surgery is aimed at improving the pulmonary blood flow. Let us see what are the different shunt surgeries available in tetralogy of Fallot. First, try to get your orientation correct. This is the aorta, and this is the pulmonary artery which is dividing like two sides. Okay. Remember, what is the aim of the shunt surgery is to improve the pulmonary blood flow. So some way or other, you have to channelize some blood into the pulmonary artery. And how it is done? Look at the first shunt. What is that? Classical Blalock Taussig shunt, which is from this artery into the pulmonary artery. Always this is a pulmonary artery, right? So what artery is being utilized here? It is the subclavian artery. Subclavian artery. Okay, right. So classical Blalock Taussig shunt, which can be remembered in the short form as BT shunt, is from the subclavian artery to the pulmonary artery. Okay, right. Now, this was the first to perform shunt surgery. Later, people performed a modification of this shunt surgery. What is that? They did not directly connect the subclavian artery to pulmonary artery. Instead, what they did was they had a conduit like this, and through the conduit, they connected the subclavian artery and the pulmonary artery. So it's something like an artificial shunt which is created using a material called as a Gore-Tex. So this shunt is also called as a Gore-Tex shunt or the modified Blalock Taussig shunt, modified BT shunt. Okay, right. And please remember for your exam, this is the most commonly performed shunt surgery. Most commonly performed shunt surgery in tetralogy of Fallot. A very important and a potential MCQ question. Okay, the third type of shunt surgery is here called as the water stent shunt. In water stent shunt, what are you doing? You are connecting this ascending aorta. Okay, ascending aorta to the pulmonary artery. That's all. What is the next one? Pot shunt. It is this area. What is this area? You are connecting the descending aorta to the pulmonary artery. That is called as a pot shunt. So there are different shunt surgeries which are available, but don't forget the most common shunt surgery is the Gore-Tex shunt or the modified Blalock Taussig shunt. So that is about the treatment options in case of tetralogy of Fallot. And with that, I am completing the discussion of tetralogy of Fallot. Now let us look at the other conditions. As you can infer from the name tricuspid atresia, there is atresia of the tricuspid valve. So very simple, the tricuspid valve which is separating the right atrium and the right ventricle like this is not developed properly. That is what is called as tricuspid atresia. Very simple. Because of this, what will happen to the size of the right ventricle? It will be very, very small sized RV. That is the point to be noted. Now, whenever the right ventricle is becoming small in size, it is not able to give the blood to the pulmonary artery. Are you able to follow? This results in greatly decreased pulmonary blood flow. That is one reason which is implicated in the causation of cyanosis in these patients. Right. Now, you should always remember this point that even though I say tricuspid atresia, it is usually not a single lesion. This is very, very important. Most of the cyanotic heart lesions are complex lesion in the sense that they have associated defects as well. So let us see what are the associated defects occurring in case of tricuspid atresia. Okay, now concentrate on the picture which I have put up. This is the right atrium. This is the right ventricle. Left atrium and left ventricle. Okay, now concentrate on the arrows which I am going to draw. From the right atrium, the blood is not able to go into the right ventricle because of complete atresia here. Okay, now what happens? The blood from the right atrium will have to escape out some way or other, right? So there is another communication like this here, which will serve to conduct the blood from right atrium into left atrium like this. What could be this communication? This communication could either be a patent foramen ovale or atrial septal defect itself. Okay, through that the blood flows from right atrium into left atrium, and from the left atrium, where does the blood flow? Into the left ventricle, and from the left ventricle it has to flow into the aorta. Now remember this important point. The blood which is actually coming into the left atrium is not fully oxygenated blood. Why? Because it is receiving some blood from the right atrium also, which is deoxygenated blood. So, on the left side of the heart, what will happen to the oxygen saturation? Will it be normal oxygen saturation or decreased oxygen saturation? It would definitely be a decreased oxygen saturation because of the mixing of the blood from the right side to the left side. Are you able to follow this? Right? So, what will happen to the level of oxygen in the aorta? That also will be low oxygen saturation. This low oxygen saturation is also another contributing factor for the development of cyanosis in a child with tricuspid atresia. That is a point to be noted. Okay. And one more defect is also associated in this particular condition. It is seen here. What is that defect? It is a defect between LV and RV, which is nothing but ventricular septal defect. Through that defect, some blood will flow into right ventricle and further can flow into the pulmonary artery. But remember, only minimal amount of blood only flows into right ventricle and then into the pulmonary artery. So that is why I was saying that before also, the pulmonary blood flow is decreased in this condition definitely, and again leading on to cyanosis. So you can understand very clearly why there is cyanosis developing in tricuspid atresia. And here comes the most important point, that in tricuspid atresia, the cyanosis is developing at the time of birth itself, or in the neonatal period itself, the cyanosis develops. This is very, very important. If you compare with the previous condition, I told you in tetralogy of Fallot, the development of cyanosis is very variable. Anywhere from birth to 4 months it can occur. But in tricuspid atresia, almost always in the neonatal period, cyanosis will develop. That is a very important feature of tricuspid atresia. Second important feature is, see, I told you most of the blood from the right atrium is getting shunted to the left atrium and left ventricle. So what happens? There is overloading of left chambers of the heart. Correct? Overloading of the left heart chambers. So what is going to happen? There is congestion on the left side of the heart. And if you take the ECG, what is going to happen? There would be left axis deviation. Correct? There is left axis deviation. This is a very, very important and a unique finding, because most of the other cyanotic heart diseases you will be reading as right axis deviation. But tricuspid atresia is the usual condition wherein a newborn baby has cyanotic heart defect with left axis deviation. Don't forget, it's an important MCQ point and often an important clue when they give you a clinical case scenario of tricuspid atresia. That should be remembered. Having discussed about the features of tricuspid atresia, you should now know about the management also. Okay. Now remember that tricuspid atresia is a condition which presents in the neonatal period itself. So you should start treatment as early as possible. The initial treatment is in the form of medical management, where you give PGE1. What is PGE1? It is prostaglandin E1 infusion, which is also called alprostadil infusion. Okay. Why are you giving this PGE1 infusion? Because this will keep the ductus patent. You all know that. Okay. What is the advantage if the ductus is patent? Through the ductus, some of the blood from the aorta will flow into the pulmonary artery. Correct? Through the ductus. See, the main problem in tricuspid atresia is decreased pulmonary blood flow. So if you give PGE1, it will improve the pulmonary blood flow. Very simple. That is how it is going to be useful. But please remember, PGE1 infusion is not a permanent solution. It is only a temporary solution. The permanent solution will be in the form of surgery only. And what you will do for tricuspid atresia is a series of procedures called as staged procedures. And what we will be doing as a surgery is different types of shunting we are going to do. There are 3 important stages or 3 important procedures which we are going to do. The first procedure or the first stage procedure is creation of modified Blalock Taussig shunt. We have just seen before in the previous topic that the role of this Blalock Taussig shunt is to improve the pulmonary blood flow, and that is what we need in tricuspid atresia. That is number 1. Number 2 procedure can be remembered from this picture, where you can see that the superior vena cava, SVC here, is connected to the pulmonary artery. Can you see that? This is the pulmonary artery which is going like this. This is PA, or the pulmonary artery. What you do is you connect the blood from the superior vena cava directly into the pulmonary artery. What is the advantage we are having now? See, the blood is not even entering into the right atrium, right? It is directly getting shunted into the pulmonary artery, thereby serving two purposes. What is the two purposes? Number one, pulmonary blood flow is increasing. Number two, if the blood is not entering into the right atrium, if the blood from the SVC is not entering into right atrium, it will not enter into the left atrium also, because I told you in tricuspid atresia, the blood from right atrium goes through that defect, which is the ASD or patent foramen ovale, into the left atrium. That will not occur. Okay. So what happened? Overloading of the left heart chambers also will not occur. So you have two advantages. What is that? One, pulmonary blood flow is increased, and number two, overloading of the left heart chambers is not occurring. That is the important point to be noted. And the name of this shunt procedure is called as Glenn shunting. That is the second stage procedure which we do in this children. Next is the third stage procedure, where we connect this blood vessel. What is this blood vessel which I am marking here? It is the inferior vena cava, IVC. That inferior vena cava blood is directly again shunted here. What is that structure? Pulmonary artery. It is shunted into the pulmonary artery. It goes like this. Okay, right. So again, what is the advantage? Normally IVC blood enters into right atrium. That is not occurring here. Instead, it is directly going into the pulmonary artery, thereby improving the pulmonary blood flow. Number one. Number two, if it is not entering into the right atrium, it will not enter into the left side of the heart also. Very simple. Thereby, overloading of the left heart chambers also is decreased. So that is the advantage of this procedure. And the name of this procedure is called as a Fontaines procedure, or the Fontaines shunt. This is the third shunt which we perform in these patients. So don't forget the order of shunt procedure in tricuspid atresia. Number one, modified blood lock Taussig shunt. Number two, Glenn shunt. And number three is the Fontaine shunt. This is about the treatment of tricuspid atresia. Now coming to the next condition, which is Epstein's anomaly. I've already told in the previous discussion itself that Epstein's anomaly association is with lithium exposure in the pregnancy. That is, a mother, when she was pregnant, takes lithium, there is a high chance of Epstein's anomaly. So lithium exposure in pregnancy is associated with this defect. Now let us understand what is this Epstein's anomaly. It is a condition characterized by downward displacement, or what we can also remember as prolapse of the tricuspid valve. Okay, right. Think like this. Normally, right atrium is separated from the right ventricle by the tricuspid valve like this. This is the normal tricuspid valve which I am drawing here. This is the normal tricuspid valve. Okay, right. In Epstein's anomaly, what happens? The tricuspid valve is not in that position. It comes down like this. Or in other word, it goes down like this. Are you able to follow this? This is what we call it as a prolapse of the tricuspid valve. Now look at the picture which I have given by the side, which displays the prolapsed tricuspid valve like this. Are you able to follow this? Right. Now what is going to happen? This part of the right ventricle, is actually now becoming a part of right atrium due to prolapse of the tricuspid valve. Correct? This is what we call it as atrialization of right ventricle. A classical description of Epstein's anomaly that you should definitely be knowing about. Okay, right. This is the description of Epstein's anomaly. Now let us understand what are the consequences of Epstein's anomaly. Because the valve has prolapsed down like this, it is not functioning properly. So what will happen? The blood from the right ventricle will go back into the right atrium, or what we also call it as regurgitation of the blood from right ventricle into right atrium. A condition which is similar to what? Tricuspid regurgitation. Very simple. So, the first consequence is regurgitation tricuspid regurgitation resulting in the blood flowing back from right ventricle into right atrium. That is the first consequence. What is the second consequence? You can see here, this is the right ventricle from where the blood is flowing. This is the pulmonary valve. This valve is the pulmonary valve and this is the pulmonary artery also. Okay, so the blood normally goes from right ventricle into the pulmonary artery like this. Now, you can understand very clearly that due to prolapse of this tricuspid valve, which is getting prolapsed like this, what is happening? It is actually occluding a part of the blood flowing into the pulmonary artery. Can you notice that? It is just going sideways also, occluding the blood flowing into the pulmonary artery. Or in other words, I can write like this. It also causes right ventricle outflow tract obstruction, RVOT obstruction, right ventricle outflow tract obstruction. What is the problem? This leads to decreased amount of blood entering the pulmonary artery. Whenever the blood entering the pulmonary artery is decreased, what is the problem? The blood flowing into the lungs also will be decreased, and that would result in cyanosis. This is the reason why patients with Epstein's anomaly develop a cyanosis. And please remember, cyanosis in Epstein's anomaly again occurs at the time of birth itself. Cyanosis at birth, or I'm going to write cyanosis in the neonatal period itself. If you auscultate these patients, a murmur can be heard. What is that murmur due to? See, I was telling you that there is a tricuspid regurgitation which is occurring. Tell me what murmur is heard due to tricuspid regurgitation. Yes, it is a pansystolic murmur. Correct. Pansystolic murmur heard in the tricuspid area. That is the second finding. Third important finding is, you can notice that there is an irregular blood flow happening in the right side of the heart. Okay, there is a combination of right ventricular outflow tract obstruction as well as tricuspid regurgitation. This results in multiple sounds which are heard, especially added sounds like clicks can be heard. So you will hear multiple sounds which are the heart sounds as well as the clicks when you start auscultating the heart in these children. The next finding is called as a quadruple rhythm. What is the reason for this? See, I told you on the right side of the heart, the blood flow is becoming very, very irregular. There is regurgitation occurring, there is outflow tract obstruction occurring. So there is a irregular blood flow on the right side of the heart. This results in multiple added sounds heard during auscultation. Some of the sound would include the ejection clicks, which are heard due to the abnormal blood flow. So what happens when you auscultate, you will not only hear the usual two heart sound, but multiple clicks also heard. That is the reason for production of quadruple rhythm in case of Epstein's anomaly. So clinical feature wise, these are the three important features I would want you to remember. Next, coming to the X-ray finding in case of Epstein's anomaly. Remember, in Epstein's anomaly, there is overloading of right atrium. I have already told you the reason. What is that? There is so much of regurgitation occurring that all the blood from the right ventricle actually enters back into right atrium itself. And also there is atrialization of the ventricle resulting in a big sized right atrial chamber. So what happened? There is overloading of right atrium resulting in big right atrium. Okay. Now we all know that right atrium forms the right heart border. So normally the right heart border should be somewhat like this. But here, because it is dilated, it has extended to this area. So right atrium is forming a border up till this area, which looks like a big box can be fit in this area. That is why it is called as the box-shaped heart. Classical X-ray finding in case of Epstein's anomaly, right? So these are the X-ray finding that you should know about. Next, in Epstein's anomaly, you should also know about some important association. One association I have already told you, antenatal exposure of which drug causes Epstein's anomaly? It is lithium exposure. That I have already told you. The next important association is with a condition called WPW syndrome. which is nothing but Wolff-Parkinson-White syndrome. What is this condition? Here there is an accessory pathway which connects the atrium and the ventricle. Not a normal pathway, but additional or an accessory pathway here. This accessory pathway is what we call it as the bundle of Kent. Okay. So what is the problem because of this bundle? It will cause early excitation because of quick transmission of impulses from the atrium to the ventricle. This is what we call it as pre-excitation of the ventricle. Okay. And an important problem in this pre-excitation of ventricle is that sometimes when it becomes excessively excited, it can predispose to arrhythmias as well. Predispose to arrhythmias. And a question can be asked in this regard. What is the commonest arrhythmia that develops in this condition? Right? It is PSVT, which is paroxysmal supraventricular tachycardia. Okay, right. That is a problem because of Wolff-Parkinson-White syndrome. Another famous question asked in this Wolff-Parkinson-White syndrome is what is the ECG finding in case of WPW syndrome. This is the ECG picture. What you can see is this is the P wave, this is the QRS complex and the T wave here. Okay, now concentrate on the QRS complex. It starts from here and ends here. It is very wide. Can you notice that almost like 3.5 small squares are covered in that QRS complex? Is this a normal QRS complex? No, it's a wide QRS complex. Wide QRS complex by definition is more than 0.08 second. If you want to remember in small squares, it is more than 2 small squares. That is what is wide QRS. That's the first finding you are noticing. Then the interval from the P wave to the QRS complex, what do you call it as a PR interval? What is happening? It is very short like this. That's all. So it is a short PR interval. That is the second feature. The third important feature is look at the arrow. At the beginning of QRS complex, you can notice that there is some slurring like this, right? And then only the proper QRS complex is noted. What is the reason for this slurring? The reason for this slurring is the pre-excitation, which is causing a minimal amount of excitation in the ventricle, and that too early. So that minimal early excitation is the reason for the initial slurring of the QRS complex like this, and this is what we call it as a delta wave. Okay, so 3 important features in WPW syndrome, which is commonly asked MCQ question. One is wide QRS, number 2 is short PR interval, and number 3 is a delta wave. Okay, so don't forget WPW syndrome is an important association with Epstein's anomaly. Finally, coming to the treatment of Epstein's anomaly. Remember, this condition also presents with cyanosis in the neonatal period itself. So in the neonatal period itself, you have to start the treatment. Initially, you can give prostaglandin E1 infusion. Again, what is the reason for this? It will keep the ductus patent. If the ductus is patent, some amount of blood will be flowing from aorta into the pulmonary artery, thereby improving the pulmonary blood flow. This can result in decrease in the cyanosis. So again, PGE1 infusion is useful in this condition also. If you remember, in the previous condition, tricuspid atresia, also I said that PGE1 infusion is helpful. Here also it is helpful. But again, remember, it is not a permanent solution. It is only a temporary treatment. You have to go for the permanent solution, which is surgery. And the surgical treatment of choice is the repair of the tricuspid valve. The name given for this is very peculiar name called as a cone repair of the tricuspid valve. That is the definitive treatment of choice for Epstein's anomaly. So that is about the discussion of Epstein's anomaly. And with that, I have completed the first set of cyanotic congenital heart defects, namely obstructive lesions with decreased pulmonary blood flow. The next type of cyanotic congenital heart defect is the mixing lesions, which are characterized by increased pulmonary blood flow. In this category, we have truncus arteriosus, transposition of great arteries, that is a TGA, hypoplastic left heart syndrome, HLHS, and one more is total anomalous pulmonary venous connections. That is what is TAPVC. Now let us look at these conditions in detail. The first condition is the truncus arteriosus. This by itself is a rare condition which is characterized by this finding, wherein suppose this is the right ventricle and on the other side is the left ventricle. Normally you should have two arteries arising from these two ventricles, namely the pulmonary artery and the aorta. However, in truncus arteriosus, there is a single arterial trunk into which both the ventricles will drain. It is something like this here. So from the right ventricle, blood enters here. Left ventricle also, blood enters into that same channel. So obviously you can understand that there is a mixing of blood in this region. So when the deoxygenated blood is going to mix with the oxygenated blood, there would be decrease in the oxygen saturation, thereby predisposing to cyanosis. In this condition also, there will be cyanosis at the time of birth itself. An important MCQ or one-liner asked in this question is, what is the association of this truncus arteriosus? In which condition it is noted? Remember, it is Digeorge syndrome. If you can remember, I'll do that part again, okay? In the first part of discussion of congenital heart diseases, I have told you about the association. At that time, I did mention Digeorge syndrome as an association. What is the association I mentioned? It is conotruncal defects, correct? Now this truncus arteriosus is one of the conotruncal defects. You should also know what are the other defects included in the conotruncal defects. These include tetralogy of Fallot, interrupted aortic arch. These are the other defects which are included in the spectrum of conotruncal defects. Now, as far as truncus arteriosus is concerned, remember, treatment is by surgery only. What is the surgery? It is called as Rastelli's procedure. Rastelli's procedure is a procedure wherein you create a partition in this truncus arteriosus like this, so that separately the channels for right ventricle and left ventricle is established. So what happened? There is no mixing of blood further, and that results in improvement. This is about truncus arteriosus. The next condition I am going to discuss is hypoplastic left heart syndrome, also abbreviated as HLHS. In this condition, the basic defect is the atresia of the mitral valve. So what is the problem? Mitral valve is the one which separates left atrium and the left ventricle. So when it is going to be atretic like this, the left ventricle is not developed at all, or it is very, very small in size. That is what is the finding which you see in this picture also. This is representing the hypoplastic or very small left ventricle. Okay, and because the left ventricle is small in size, there would be decreased blood flowing into the aorta as well. Okay, so decreased blood flowing into the aorta. Okay, decreased blood flow in the aorta, as well as the size of the aorta will be very small. That is what is represented in that picture. Can you see that this is the aorta, which is actually small in size? So I'm going to write hypoplastic aorta. Now, another important associated defect in this condition is most patients have this atrial septal defect. You can see that this is the right atrium and there is a hole in that interatrial septum. That is why it's called as a atrial septal defect. Through the atrial septal defect, there would be mixing of blood occurring. That is why this condition is considered as a mixing lesion. Okay, right. Now, what is the main problem in this particular condition? There is very much low amount of blood flowing in the aorta, because of which the systemic circulation gets compromised and the organs I'll do it again, and the systems will receive very less amount of blood. So what happens? It results in shock as a presentation. That is a characteristic presentation. In the neonatal period, the child would present with shock. What is the other type of presentation? Because of block at the level of the mitral valve, there is so much of congestion inside the other chambers of the heart. This congestion will result in development of congestive cardiac failure. Again, congestive cardiac failure also occurs in the neonatal period, and that too in the first week of life itself. So this is a very famous question. What is that? Hypoplastic left heart syndrome is the most common cause of congestive cardiac failure in the first week of life. These are the main problems encountered in hypoplastic left heart syndrome. As you could infer from the findings, since this has severe manifestation starting in very early life, the prognosis is poor for hypoplastic left heart syndrome. So what will be the treatment for this particular condition? Initially, you can try medical treatment in the form of prostaglandin E1 infusion. What is the role of PGE1 infusion? It keeps the ductus patent. And how it is going to help in this condition? Because the ductus is kept patent, some amount of blood can flow from the pulmonary artery into the aorta, thereby improving the circulation in the aorta. However, remember, PGE1 infusion, as always I say, it is only a temporary measure. The final treatment is going to be surgery only. The surgical correction of the defect is called as Norwood's procedure. This will be the final treatment for hypoplastic left heart syndrome. The next lesion I am going to discuss about is transposition of great arteries or TGA. What is the problem? There is change in the position. That is what is called as transposition. Great arteries refers to aorta and the pulmonary artery. So basically it is a change in position of the aorta and pulmonary artery. How it is occurring? You can see the picture. This is the right ventricle. Normally from the right ventricle, you should have the pulmonary artery arising. But here, what is arising? Aorta is arising. That is the problem. So aorta, instead of arising from the left ventricle, is arising from the right ventricle. That is the first thing. On the opposite side, from the left ventricle, normally aorta should arise, but here the pulmonary artery is arising. So this is what is called as a transposition of great arteries. Let us see what are the consequences of this. We'll start with the right atrium. The blood from the right atrium flows into right ventricle, but here from the right ventricle, aorta is arising. Through the aorta, it gets distributed to the system, or the systemic circulation happens. From the system, there would be venous return again to the right atrium. This is via SVC and IVC. What happens on the left side? There is left atrium, blood flows into left ventricle. In this condition, from the left ventricle, what is arising? Pulmonary artery is arising, which goes to the lung, and again, from the lungs, the venous circulation comes to the left atrium via the PV or the pulmonary veins. Now you can see that there is no crossover between the two circulations. That is why it is called as parallel circulation. Okay, now transposition of great arteries is divided into two main categories. One, TGA. It is called as a pure TGA, or also called as TGA with intact ventricular septum. Okay, just remember like this. Why? Because the other type is TGA associated with another defect in the form of VSD, or the ventricular septal defect. Okay, so there are two varieties, pure TGA and TGA with a ventricular septal defect. In the first variety of TGA with intact ventricular septum, what happens? There is intense cyanosis which is starting at birth or soon after birth. That would be the typical presentation. Whereas if there is TGA with VSD, what is going to happen? So here is the ventricular septal defect. Through that, some of the blood from the left ventricle goes into the right ventricle. What is the type of blood in the left side of the circulation? Yes, it is the oxygenated blood, right? So some of the blood, oxygenated blood, will go to the right ventricle, and from the right ventricle it goes into the aorta here. So what will happen? Aorta will receive some amount of oxygenated blood. So do you think this condition is better than the previous one? Absolutely yes, because there is some amount of oxygenated blood which is happening in this particular condition. So these patients will have less severe cyanosis, or in other words, not an intense cyanosis. That is the point to be noted. And because of the presence of ventricular septal defect, when you examine these patients, you will have the classical finding of pansystolic murmur. What is the other feature? I said some blood from the left ventricle goes into right ventricle, but majority of the blood from the left ventricle will follow the natural path only. What is the natural path here? It is from the left ventricle, it is majorly entering into the pulmonary artery. So what happened? More blood is entering into the pulmonary artery only. When it enters into the pulmonary artery, it is again going to enter into the lungs, causing congestion inside the lungs. After some time, what will happen? It will come back again into the left atrium only, or into the heart only, causing congestion in the heart also. Ultimately, this leads to what problem? Yes, it is congestive cardiac failure. So, patients with TGA and VSD also have congestive cardiac failure which is developing. Okay, and when you start examining these patients, because of the ventricular septal defect, you will have the classical murmur. What is that? Pansystolic murmur. So these three features are the characteristic features associated with TGA with the ventricular septal defect. And in patients with TGA, if you take the X-ray, there is a very classical finding which you are seeing in this picture. What is that? It is the heart shadow like this, with a relatively narrow area above the heart chambers like this. What is the reason for this relatively narrow area? Think like this. My left hand is like the aorta and right hand is like the pulmonary artery. This is the normal arrangement of the arteries. Okay. But in TGA, what happens? The aorta comes to the front and to the right side like this, and the pulmonary artery goes to the back and left side like this. So what happens? The arteries are placed front and back like this. Rather than being parallel, they are placed front and back like this. So that is the reason why the area above the heart becomes narrow like this. Are you able to follow? It looks like what? A string which is attached to the egg like this. This is what is called as a egg on string appearance, also called as the egg on side appearance. The classical X-ray finding of transposition of great arteries, which you should be knowing about, and it has been asked so many times in the exam. Now coming to the treatment of transposition of great arteries, it depends on whether it is associated with VSD or without VSD. The first condition is TGA with intact ventricular septum. Here it is an emergency because I have told you that these children, they present in the neonatal period itself with intense cyanosis. So emergency intervention has to be done. What can you do first? First, you can give the prostaglandin E1 infusion. What is the reason for this? When you give prostaglandin E1 infusion, what will happen? The ductus is open. So what happens? There will be a communication which will be opening up between the pulmonary artery and the aorta, and this would result in some shifting of the blood from the pulmonary artery into aorta, thereby improving the aortic circulation. Are you able to follow this? So that is why initially you can give a trial of prostaglandin E1 infusion. But again, PGE1 infusion is not a definitive treatment. You have to go for further treatments, which will be the surgical procedure. The next step in the management is a name of a surgery called atrial septostomy. Here we make a small nick in the interatrial septum, or in other words, it is a sort of creating like a atrial septal defect. What is the advantage? That will allow the blood to come from the left atrium into right atrium. This will also help in the situation because some blood from the left side comes to the right side. This is called as atrial septostomy. The name of this procedure is called as a Rashkin procedure. Okay, and the final treatment is going to be the definitive treatment for TGA, changing the position of the great arteries to the correct position. That means changing the aorta to the left side and pulmonary artery to the right side. And this is called as arterial switch procedure. This is also called as the Jatens procedure. That is a definitive treatment option for TGA. Okay, right. Now, if the patient is having TGA with ventricular septal defect, as I said, this will have only mild form or less intense forms of cyanosis, and the presentation also will be little delayed. Or in other words, you can perform the treatment little later than the other condition. So here in TGA with VSD, you can directly perform the definitive surgery, which is Jatens arterial switch procedure. Which can be performed little later. Here the timeline is within 3 months after birth you have to perform. Whereas the other condition, that is TGA with intact ventricular septum, I told you it's an emergency. So the Jatens procedure should be performed little early. According to the guidelines, it is within 2 to 4 weeks after birth. Okay, so that is about the definitive treatment for TGA. I have told you about the salient points of transposition of great arteries. The last condition is called as total anomalous pulmonary venous connection, or TAPVC. So as you can infer from the name, it is the anomaly of the pulmonary veins. What is the anomaly? In simple terms, from the lungs, the pulmonary veins, that is PV, should come into the left atrium of the heart. That is what is a normal one. The anomaly is, instead of coming into the left atrium, the pulmonary veins, they drain into right atrium. This is what is the anomaly. Now we are going to see this in detail. Please remember that there are 4 types of TAPVC. One is supracardiac type. Second is cardiac type. Third is infracardiac type. And the last one is a mixed variety. Please remember that out of these 4 types, the most common overall type is the supracardiac type. So I am going to discuss that in detail first. So what is going to happen in supracardiac type? From the lungs, all the pulmonary veins join together and form the vertical vein. Then they enter into the innominate vein, which is also called as a brachiocephalic vein. And we all know that those brachiocephalic veins will join to form the SVC. So what happens? Next, it is going to enter into the SVC. So have a look at that flow again. From the lungs, it goes like this, joins the innominate vein and later joins the superior vena cava. We all know that superior vena cava enters into the right atrium of the heart. So through the superior vena cava, this blood also will enter into the right atrium. So that is what I was saying. The pulmonary venous return from the lungs, instead of entering into the left atrium, here it is entering into the right atrium. Can you see all this process is happening above the level of the heart like this? So that is why it is called as supracardiac type. Let us see what is going to happen further. Blood from the right atrium goes into right ventricle and then goes into the pulmonary artery. This is a normal pathway. However, in TA-PVC, almost all cases will have a communication like this between the right atrium and the left atrium. What is that? It could either be a patent foramen ovale or commonly it is a atrial septal defect. So what happens through this defect? Some of the blood from the right atrium will enter into the left atrium also through this defect, and from the left atrium it will enter into left ventricle as well as into the aorta. But please don't forget, what is the blood which is entering into the aorta? It is a blood which has started from the right atrium. Remember, right atrium does not contain purely oxygenated blood. It contains mostly deoxygenated blood from the SVC and IVC. Only some amount of oxygenated blood from the pulmonary vein has come into the right atrium. So if I ask you the question, what would be the majority of the blood in the aorta? What is going to be your answer? It is going to be majorly deoxygenated blood only. Okay. This is the reason that the patients with TA-PVC develop cyanosis, because in the aorta or in the systemic circulation there is majorly deoxygenated blood only. But please remember, there is mixing with the oxygenated blood also. So if there is a question, if these patients will present with intense cyanosis, no, they are not going to present with intense cyanosis. They are going to present only with mild cyanosis. That is the point to be noted. Okay, right. The next point to be noted is that look at that usual pathway for the blood to go. From the right atrium, it goes majorly into right ventricle and majorly into the pulmonary artery. So what happened? Majority of the blood from the right atrium is entering into the pulmonary artery only. So pulmonary artery receives more blood. From the pulmonary artery, you know where the blood is going to go into. What is that? Going to go into the lungs, causing congestion inside the lungs. After some time, what will happen? The blood is again coming back to the heart only, causing congestion in the heart also. So what should be the next finding in this patient? They also develop features of congestive cardiac failure. That is a next point to be noted. The third point, I told you these patients majorly have ASD has an associated defect. So when you start examining these patients, you will have features of atrial septal defect. What is that? I've already told you this in the previous module. What is that? Yes, the feature of ASD will be wide fixed splitting of second heart sound. So these three are the salient features in TA-PVC supracardiac type. What is that? Cyanosis, congestive cardiac failure, plus wide fixed splitting of second heart sound. Okay, right. Next, some findings on investigation in these patients. Suppose I do the estimation of oxygen saturation in the different chambers of the heart, what will be the finding? Remember, there is a mixed blood entering into the right atrium. Mixed means mixture of the SVC, IVC as well as the pulmonary venous blood entering into right atrium. And from the right atrium only, you can see that blood is going to all the chambers. Can you note that? It is going like this. It is going in the other way like this. And from there it is going like this. So what happened? From the right atrium only, blood is going to all the different chambers of the heart. So what will happen to the oxygen saturation in the different chambers of the heart? It will be the same as that of the right atrium. Or in other words, I can write like this: in all four chambers of the heart, oxygen saturation remains the same. And this was one of the recently asked exam question which you should make a note of. Okay, that is one question. Second question, if I take X-ray in these patients, what I am going to get as a finding. You see here, I told you from the lungs, the pulmonary veins are finally entering into the SVC, and from SVC only they are entering into the right atrium. Now you can imagine what will happen to the size of the SVC. Very simple, it will undergo dilatation. Are you able to follow this? It will undergo dilatation. How does this get reflected in the X-ray? Let us see. Sometime back we were discussing about the normal cardiac borders on the X-ray. I'll just quickly go through that. On the right side you have the right atrium forming the heart border, and above that is the prominence formed by the SVC. On the left side you have the prominence of the arteries above, and below that you have the heart chambers which are forming the heart borders. What is that? Left atrium and left ventricle. This is normally there. Now in TAPVC, what is going to happen? I told you SVC is undergoing dilatation. So that border will not be straight like this. It would be little bit distended like this. Why? Due to SVC dilatation. Okay. So how does it look like? What number it looks like? It looks like the number 8. Can you notice that? So this is called as a figure of 8 appearance. Okay. There is also another name for this figure of 8 appearance. What is that? Look at this X-ray. You can see some structure flashing in between. What is that? It is a snowman. Okay. It is also called as a snowman appearance. The other name is cottage loaf appearance. All these are classical findings associated with TAPVC on the X-ray, which you should make a note of. That is all about the first type of supracardiac TAPVC. What are the other varieties? Cardiac TAPVC. In cardiac type of TAPVC, what happened? From the lungs, the pulmonary veins emerge out, but instead of joining the SVC, they will directly join the right atrium. That is the difference. So what happened? It does not go above the level of the heart. That is why it's not called supracardiac type. Instead, it directly enters into the heart. So that's why it's called as a cardiac type of TAPVC. So what are the points to be noted? This will also have similar features to the supracardiac type. What are the features? Quickly recollect. They will have mild cyanosis. They will have features of congestive cardiac failure. They will also have features of ASD, which is wide fixed splitting of second heart zone. Only thing to be noted is because SVC is not involved in these connections, it won't be dilated. Or in other words, figure of 8 appearance is absent in the X-ray. That is the point to be noted. So all features will be similar except no figure of 8 appearance or no snowman appearance. That's all. What is the last variety of TAPVC? It is infracardiac TAPVC. Okay. So what happens here? From the lungs, the pulmonary veins are arising, but they are going below the level of the heart. That's why it's called infracardiac TAPVC. So from the lungs, let's imagine that this is the region of the heart. Imagine. The pulmonary veins are going below the level of the heart like this. Pulmonary veins. So that's why it's called infracardiac TAPVC. They are going like this. And they will join a venous structure here. This venous structure could either be an IVC or hepatic vein or the portal vein. Any of the structure it can connect into. But here is a major problem. What is that? Infracardiac TAPVC is also called as obstructive TAPVC. Why? Because at the level where they are joining with these veins, the pulmonary veins undergo lot of obstructive changes here. So all this area will undergo obstruction. That is a major point. So what is going to happen? The blood will not even enter into the venous structures, resulting in increased pressure in the pulmonary veins, or what we call it as pulmonary venous hypertension. And what will happen? All the blood will stay inside the lung itself, causing too much of congestion inside the lungs. Okay? And because the blood is not even entering into the veins or the heart, this child will present with intense cyanosis at the time of birth itself. Intense cyanosis at the time of birth itself. Very, very important point. And if you take the X-ray in these children, how does it appear? Due to the combination of extreme congestion inside the lung as well as pulmonary venous hypertension, you will get fully white colored lung fields or white out lungs. That is a classical X-ray picture of TAPVC. White out lungs is also called as a ground glass appearance of the lungs. At this point, I would want you to quickly recollect what are the conditions where you have ground glass appearance of the lungs. Number one is we have studied in our neonatology modules. What is that? RDS, which is respiratory distress syndrome. The second condition is PAP, which is pulmonary alveolar proteinosis. Again, I have discussed that condition in the neonatology modules. And third is the condition which we are discussing, which is obstructive type of TAPVC. This is an important exam question, so I want you to know very clearly about this. Finally is about the treatment for TAPVC. Please remember, treatment depends on whether it's an obstructive lesion or a non-obstructive lesion. As I have said just before, all infracardiac TAPVCs are obstructive conditions, whereas supracardiac and the cardiac variety are usually non-obstructive lesions. Please remember, the only treatment option is surgical correction, nothing else. But the timing of surgery is dependent on whether it's an obstructive or a non-obstructive lesion. For example, I told you that infracardiac lesion or the obstructive lesion, they present with intense cyanosis at the time of birth itself. So that is more like an emergency. So surgery should be done as early as possible. So surgery should be done as early as possible. In non-obstructive conditions also, surgery should be done, but it is not a very much of an emergency. You can do in the first few months of life. Typically, within the first 2 months of life, surgery should be done. That is what is a guideline recommendation. Now, one more important point I would want you to remember. In most of the previous condition, I told you that in the neonatal period, if you want to treat a cyanotic congenital heart disease, the first step which you will mostly do is administration of prostaglandin E1 infusion to make the ductus patent. I hope all of you can remember that. But in infracardiac or the obstructive variety of TAPVC, PGE1 infusion should never be attempted. In fact, PGE1 infusion is contraindicated in case of infracardiac TAPVC. What is the reason for this? The simple reason is, if you give PGE1, the ductus will be open, right? When the ductus opens, what will happen? There will be further inflow of blood from the aorta into the pulmonary artery, later into the lungs as well as the pulmonary veins. But you know that the pulmonary veins are already getting congested, right? So what happened? It will further increase the congestion inside the lungs due to obstruction. So that is why PGE1 infusion is absolutely contraindicated in case of infracardiac or the obstructive variety of TAPVC. I hope this point is clear, and this has been asked in one of the competitive exams. So you should make a note of it. So that is about the discussion of TAPVC. With that, I have completed the discussion of all cyanotic congenital heart diseases. Please note one point in congenital heart diseases. The topic may look to be little complicated or little lengthy, But what I want you to remember is to understand the concepts behind every congenital heart disease. Don't try to read it as point-wise. Instead, try to read it as concepts, which I must have explained at the beginning of every congenital heart disease. Make sure you know it thoroughly. Once with that basic, if you read further, definitely you will be able to recollect all the points about every congenital heart diseases. With that, I end the discussion of cyanotic congenital heart diseases in children.